Hello everyone and welcome back to Studious students. In this video we'll discuss peptic ulcers including acute ulcers, chronic ulcers, pathogenesis, morphology, complications and clinical features. Peptic ulcers are areas of degeneration and necrosis of GIT mucosa exposed to acid peptic secretions. It occurs due to exposure of HCl and pepsin. Now coming to the ratio is 4 is to 1. For every one gastric ulcer, it equals to 4 duodenal ones. Acute peptic ulcers are usually small, multiple mucosal erosions, as you can see in this image. Unlike chronic ulcers, they are generally superficial and do not penetrate deeply into the wall. The stomach is the most common site. These ulcers are classically associated with severe stress on the body. But what exactly do we mean by stress here? Let's see the causes. Several conditions can lead to acute stress ulcers. Psychological stress may contribute, but more important are severe physical stresses. This include major trauma, shock, sepsis, and severe intracranial lesions. Ulcers associated with intracranial lesions are called Cushing ulcers. All of these conditions ultimately damage the protective mechanisms of the gastric mucosa. Apart from these causes, certain drugs and local irritants can also trigger ulcer formation. Drugs such as aspirin and other NSAIDs are important causes of acute ulcers. These drugs reduce prostaglandin synthesis, weakening mucosal protection. Local irritants like smoking and alcohol further damage the gastric lining. Together, these factors increase susceptibility to ulcer formation. Now let's understand the mechanism behind stress ulcer development. Imagine a patient involved in a major car accident. Severe trauma can lead to massive blood loss. As blood volume falls, the body enters a state of shock. During shock, the body redirects blood flow to vital organs such as brain and heart. As a result, blood flow to the stomach decreases significantly. What happens next? The reduced gastric flow causes ischemic injury to epithelial cells. These are the epithelial cells. When these cells are damaged, the protective mucous barrier begins to break down. Once the barrier is lost, acid can diffuse back into the tissues. This acid mediated injury rapidly damages the mucosa and leads to acute ulcer formation. Grossly, acute ulcers are usually oval in shape and are generally less than 1 centimeter in diameter. They are often multiple, with several ulcers occurring simultaneously. Because they are shallow lesions, they usually involve only the mucosa and superficial layers. Now let's move on from acute ulcers to the much more common chronic peptic ulcers. Chronic peptic ulcers develop due to an imbalance between mucosal defense mechanism and acid peptic injury. The most important cause worldwide is Helicobacter pylori infection. NSAIDs such as aspirin are another major cause. Increased acid and pepsin secretion also contribute to mucosal damage. However, these are not the only risk factors. Other contributing factors include chronic gastritis, smoking, alcohol consumption, dietary influences, and psychological factors. All of this can weaken mucosal defenses and increase susceptibility to ulcer formation. Certain systemic conditions may also play a role. Some studies have shown an association between blood group O and duodenal ulcers. Hormonal disorders that increase gastric acid secretion can also predispose individuals to ulcer formation. A classic example is parathyroid adenoma, which may increase gastric acid production indirectly. Now let's focus on how duodenal ulcers develop. The first mechanism is hyperacidity. Excess gastric acid enters the duodenum. The duodenal mucosa is exposed to increased acid load and becomes injured. Repeat injury eventually leads to ulcer formation. In some individuals, gastric contents empty too quickly. Acid reaches the duodenum before adequate neutralization can occur. The duodenal mucosa is therefore exposed to strong acid for prolonged periods. This repeated exposure contributes to ulcer development. But the single most important factor remains Helicobacter pylori. Helicobacter pylori produces several virulence factors including urease, protease, and phospholipase. These enzymes help the bacteria survive within the stomach and damage the protective mucous layer. The organism also releases several toxins such as CAGA and VACA. This toxin directly injure epithelial cells and trigger inflammation. Epithelial damage stimulates the release of inflammatory mediators including interleukin 1, interleukin 6, interleukin 8, and tumor necrosis factor alpha. This inflammatory response weakens mucosal defenses. Once the protective barrier is compromised, acid and pepsin can damage the tissue more easily. The result is formation of a chronic duodenal ulcer. Gastric ulcers differ slightly from duodenal ulcers. Here, the major problem is not excessive acid production but impaired mucosal defense. There is reduced quantity and quality of mucus. Helicobacter pylori infection causes chronic gastritis and weakens protection further. Additional factors such as bile reflux, smoking, and chronic gastritis also contribute. Together, these factors allow acid to damage the gastric mucosa. Chronic peptic ulcers most commonly occur in the first part of the duodenum near the pyloric region of the stomach. They are usually solitary lesions. Unlike acute ulcers, they are deeper and can extend through the muscular layer. Let's now examine the microscopic appearance. Microscopically, chronic ulcers show a sharply punch-out defect. The surrounding mucosa often shows feature of chronic gastritis. Fibrosis develops in the base of the ulcer as part of the healing process. Blood vessels may become thickened due to repeated injury and repair. The ulcer actually shows distant histological layers. A chronic peptic ulcer shows four characteristic layers from top to the bottom. First is superficial exudative zone containing fibrin, neutrophils, and debris. Beneath it lies the necrotic zone, which contains tissues that have been destroyed by the acid and pepsin. Next is granulation tissue zone containing new capillaries and fibroblasts indicating healing. Finally, at the base is the zone of cicatrization, which is dense fibrous scar tissue. The surrounding mucosa remains intact and regenerating. These four layers are a classic microscopic hallmark of a chronic peptic ulcer. The first complication is obstruction. Repeated cycles of injury and healing produces fibrosis and scarring. When this occurs near the pyroris, pyloric stenosis may develop. Patients can present with gastric outlet obstruction. Hill ulcers may also produce a characteristic deformities such as an hourglass stomach. Hemorrhage occurs when an ulcer erodes into a blood vessel. This can result in chronic blood loss, anemia, or even life-threatening bleeding. Perforation is another serious complication. When the ulcer penetrates to the full thickness of the wall, gastric contents spill into the peritoneal cavity, causing peritonitis. An important exam sentence is that cancers ulcerate, but ulcers rarely cancerate. Peptic ulcer commonly affects 50 to 60 years old. It also affects people with higher stress, for example, a leader. Attacks usually last from 2 to 6 weeks, and freedom interval is between 1 to 6 months. In gastric ulcers, it occurs after eating food and there's no night pain, whereas in duodenal ulcer, there's night pain. This is an important point that you should note down. In vomiting, gastric ulcers have vomiting, but duodenal ulcers have no vomiting, they only have heartburn. In duodenal ulcers, they can eat anything, whereas in gastric ulcers, they can only eat milk, eggs, etc. There's weight gain in duodenal ulcers because they can eat anything, whereas in gastric ulcers, there's weight loss. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe to Studio Students. See you in the next video.